Welcome back to the second half of today's conference. I request you to please come back, whoever in the outside, as we are going to start our post-lunch affairs. Continuous glucose monitoring estimates glucose levels and wirelessly sends the information to a software program. To update us regarding this, we have the two brightest minds with us in this gathering. So why not I call upon Dr. G.P. Bhattacharya, one of the famous medical practitioners in Howrah, also the backbone of HDS, and Dr. Arindam Ray, consultant endocrinologist and assistant professor, WBMAS, Kolkata. So Dr. G.P. Bhattacharya and Dr. Arindam Ray, please come over the stage. Yeah, okay. And we have Dr. Supriya Datta with us, the senior consultant physician and diabetologist, who will moderate this session. Thank you.
Good afternoon all. So today our session post-lunch is CGM, continuous glucose monitoring. It's better I stand and tell. Continuous glucose monitoring, as we all know that glucose control these days with enormous of advances in pharmacotherapy and weight-reducing molecules, but still patients land up with complications. So glucose monitoring is one of the cornerstones of management of diabetes. And this has to be highlighted upon to our patients because they are only aware of medications. Even for lifestyle also we have to harp on them. But for monitoring, this is a totally different ball game because patients are not aware of what this monitoring will help. They know only about lab values, fasting and PP. And latest HbA1c, they are now somewhat aware of. But about the glucometers and the continuous glucose monitoring, our patients are not aware of. So the job lies on us to know about the latest advances in glucose monitoring. And apart from a structured SMBG chart, self-monitoring of blood glucose with a glucometer, there has been a lot of advances in glucose monitoring. And continuous glucose monitoring devices have been on our evolution over the last 3-4 decades. And we are fortunate to use it over the last 7 to 8 years with the launch of the Freestyle Libre systems, as well as along with the insulin pump, we have the Medtronic's Guardian Connect, and there are other CGM devices, Dexcom 4, 5, and 6. And our Indian pharmaceutical houses are also keen to manufacture cheaper variants because these all come with a price which are being imported and we cannot give the benefit. So today's session will be discussed the importance of monitoring, blood glucose monitoring, what is ambulatory blood glucose profile or monitoring, what is intermittently scanned, and what is a true continuous glucose monitoring. For this, I invite our esteemed speaker, a budding endocrinologist, Dr. Arindam Ray, to go to the details and make you comfortable with it. Arindam? So first, get a look of the device. Many of you are using it. So the commonest which we use is the Freestyle Libre. this is there, and Dr. Guru Prasad Bhattacharya will demonstrate in details how it is to be applied. I have been using it for the last 7 years. Since its inception, we have got the Libre Pro, which is a professional variety where the sensor has to be applied with an applicator. Basically, I would explain the sensor. A CGM system consists of 3 parts. One is the sensor, which actually measures the interstitial blood glucose. We have an applicator and a device which is applied over the skin. This is the device, sensor device applicator, and this is the sensor. There are 2. You can continue. There are 2 components. One is the applicator and one is the device. The device sensor is here. Just you have to, no, don't do like that, because if you do in the hand, there is a marker over here and there is a groove over here. You have to fit the groove in the marker. Just simple. There is a marker here in the applicator and there is a groove in the sensor device, and you have to just keep on the table and press it. Once you press it, the sensor comes here. It was here. This is the applicator. It has a spring so that we can put it in the hand. So any of you interested in doing can put it for 14 days.
This sensor can measure interstitial glucose and convert that interstitial glucose readings to plasma glucose readings, and that could be had in the mobile device or the computer connected to the sensor, and it can be used for up to 14 days. Anybody interested can put it on their arm, outer aspect of the arm. And Supriya Di will be putting. This is nowadays. This is offered by Eris Pharmaceuticals, and it is available in Amazon. And different varieties available in Amazon. You can purchase that. That's not very high price. About 40.
I know the details because I'm actual price of the reader. There are 2 variants. One is I was going through that. One is the Pro, where the reader is with the doctor or the healthcare professional and the sensor is to be purchased by the patient. Eris Pharma is offering free. That's a different story, but in practical terms, if you want to make your patient purchase, so it costs around 5,000, the sensor. Now the latest variant is the Libre systems. It contains the sensor as well as the reader. The reader patient is purchasing and the price is around 11,000, but there are offers. The reader is permanent. It can be with the patient like a glucometer. After the sensor purpose is solved, there are strips for using it as a glucometer. Now that is the true continuous glucose, intermittently scanned glucometer, because the sensor applied, the patient can see it himself or herself. But for this device, the Pro one, you just activate and the patient comes after 14 days. So it is not actually a true continuous glucose. It's giving the trend and the pattern after 14 days. But the one which are used now, if the patient can afford, that has the device, the sensor along with the reader. And that costs around 11,000, but it can be procured at around 10,000, of which the reader is permanent and the sensor will be used again. So that is the thing. And now there is, I would like to highlight recently, the Freestyle Libre systems has come with a link, Libre View, which your mobile device, if it has NFC like Bluetooth, you don't require to purchase the reader. That is very, very much utilized because the price comes down. It is available around 5,000, the sensor, and the patient can see it in their mobile phone, which has NFC. All the iOS, Apple phones have it, and some of the Motorola and all, they have it. Samsung, Motorola, they have NFC. So it's not that costly. See, the indications Arindam will tell. If you have a patient on multiple dose of insulin, the best possible way of monitoring is a CGM device. So without wasting time, I'll apply it on sir. So
বাঁহাতে করো, বাঁহাতে। ওরা না, বাঁহাতে।
হ্যাঁ, বাঁহাতে, রাইট হ্যান্ডে বাঁহাতে, ডান হাত যে কোনো হাতে করতে পারেন। একটু স্টেরিলাইজ করার কিছু আছে?
না, স্টেরিলাইজ করার কিছু নেই।
ঠিক আছে।
স্টেরিলাইজার কিছু আছে?
Yes, there will be a prick because the sense the needle has a inside a capillary. You won't like it.
কিছু লাগবে না, কিছু হবেই না তোমার, তুমি এটাকে রিলিজ
ইয়ে
করো।
আছে, টেপ আছে,
কিছু
টেপ, সেলো টেপ বা কিছু খুলে যাবে তো, পরে লাগিয়ে দিও, একটা কিনে এনে লাগিয়ে দিও, কিছু লাগবে না,
কিছু লাগবে না। দেখো হাত থেকে রিলিজ করো, ওটা ওখানে লেগে থাকবে।
So just lateral aspect of the arm in this manner. So this is the sensor. So this is the sensor. It's stuck up. There is a sensor, a platinum chip, and there is a capillary which has been pushed in. Khub laglo, sir?
No.
Okay, fine. Not yet. It will not be painful. The only thing, this is secured, but preferably we give another micropore to give it a protection. And he can wear it 24 hours of the day. He can bathe, he can go to the gym, nothing will happen. Only thing, he should not just give a blow on it. Dorjay dhakka takka lagaben na. Okay, fine. Now this is the reader. Here, get a sensor, new sensor, it's there, data, and after it is activated, it will take 60 minutes to get activated. After that, whenever we put this at a distance of up to 1.5 inch, you can record. So now I will start new sensor. So there is a click, there is a sound, the getting sensor, check sensor status when prompted in 2 minutes. So 2 minutes it will show that the device has been activated. Okay? So হয়ে গেছে স্যার, একটাই শুধু 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 লাগালেন, খুলে না যাতে যায়, আর একটা ওই মাইক্রোপোর লাগিয়ে দিতে হবে।
এটা রিডিং কি পাওয়া গেল?
এই রিডিংটা তো এখন পাবেন না, আফটার 60 মিনিটস দ্য সেন্সর উইল স্টার্ট ওয়ার্কিং। আগে ইন্টারস্টিশিয়াল ফ্লুইড যাবে, অ্যাক্টিং হবে, মানে অ্যাক্টিভেট হতে হবে। এবং এইটা প্রো, এইটা দিয়ে আপনি না, আপনার 14 দিন পরে এর আগে আপনার রিডিংটা নেবে। আর আপনার যদি মোবাইল ডিভাইস থাকে,
মোবাইল ডিভাইস
আছে যার এনএফসি আছে, সেখানে আরেকটা অ্যাপ আছে যেটা আমি এত বছর ধরে করি, গ্লিম্প বলে। গ্লিম্প অ্যাপ এখন লিব্রে ভিউ ডাউনলোড করে নিতে হবে মোবাইলে, ওটা দিয়েও দেখা যাবে উইদাউট দিস রিডার অলসো।
গুরু তুমি পারবে তো?
ওইগুলো আমি বলে দেবো।
60 মিনিটস থাকবো না, এই জন্যই। ঠিক ঠিক আছে, ওকে ওকে,
থ্যাংক ইউ। হ্যাঁ, টেক কেয়ার অফ এভরিথিং। আর ওইটা একটু ইয়ে করে দেবে, নাহলে খুলে বেরিয়ে যাবে। স্যারের ডায়াবেটিস আছে, তাই জন্য স্যার না। So Arindam, you are ready?
Okay.
Demonstration is done. So go through the nitty-gritties of CGM. Thank you, Arindam.
So at the outset, good evening, good afternoon to everybody, and thanks Howrah Town Diabetic Society for giving me the opportunity to discuss here about this CGM, and thanks the chairperson Supriya ma'am and GP sir for kind introduction. So it's a beautiful demonstration that has been already given how to Hello. Okay. So how to apply this device on patients' arm, and how to actually, sir is a bit panic about whether it's painful or not. But this is a true message that we have to deliver to the patient, that it's absolutely painless. And there is some issues with the adherence of this, the device over the skin because of increased sweating, because of our, the climate. So that makes some sense for some kind of patient. But truly speaking, it's a very, the important tool of diabetes management nowadays. So this is the status of HbA1c in a patient. You can see the 3 patients who have done this CGM, and we can see in all the 3 patients HbA1c is 7%. So what till date we are managing diabetes with, like the fasting sugar, the PP sugar, and the HbA1c. But nowadays this glycemic, the painter that has been introduced for diabetes management, that includes the glycemic variability and the quality of life. So you can understand from this slide that even if the patient's HbA1c is 7% in all 3 patients, you can see the last patient have the 100% who is in the time in range. This is the target range of the patient, and the other 2 patients have the glycemic variability, and the first patient has a huge glycemic variability, whereas the middle patient has a bit less, and the third patient is 100% in range of blood glucose. So these are the questions that we wonder about the quarterly A1C, that what times of the day are in range of the blood glucose, whether it's a high, whether it's low, and why it's occurring. Should the medication dose be adjusted? The timing of the medication can be adjusted. What is the the issues that goes with the food, sleep, exercise, stress, definitely whether it is working, whether it's not working, the medicines, and if I just made a change in a part of the day, whether it will make any difference. And again, the quality of life, the level of diabetes burden, the experience, experiments that should I go forward. So these are the questions that definitely we don't have the answer with the A1C. So that's why we have to go beyond A1C. This is the inter and interday glycemic excursion. The hemoglobinopathies, the anemia particularly, these are the important concerns of falsely giving the A1C value. In some aspects it gives the false high value, in some aspects it gives a false low value. The treatment adjustment regimen when the levels when it's particularly elevated. The hypoglycemia, because HbA1c is a very good correlator with the hyperglycemia, but truly speaking the hypoglycemia is a very little understandable with the A1C. Again, that there are differences with the ethnic and racial differences in the A1C level, and definitely the personalized diabetes management, that is the crux of diabetes treatment in recent days, different guidelines, that the individual patient who is sitting in front of you have to personalize treatment, so that we can't differentiate from this A1C. So this is a game changer, definitely, and this is the AGP report that we get from any of the patient with this AGP, and we can see this is the ambulatory glucose profile. So ambulatory glucose profile is nothing but a summary of the continuous glucose profile over a part of time, like the 14 days, as madam said. Coming to this is the daily glucose profile, that when the patients actually do this, the measurements, they actually take the daily glucose of this of this interstitial glucose, and you can see the difference in the different days, starting from Tuesday to Sunday, the glycemic excursion, different part of the time of the day that varies even in the single patient. So this continuous glucose monitoring system that gives the records of the glucose throughout the day and night. It picks up even 24 hours around 480 glucose measurements, and that gives average blood glucose up to 6 days, while the person with diabetes continues daily activities at home, at work, at his own place. As madam said, even you can bath or gym or can do any activities without interruption. So this is a principle that we measure the interstitial fluid here, and the interstitial fluid closely correlates with the plasma glucose. It is a minimally invasive enzyme-coated electrodes that we place here, and this interstitial glucose concentrations continuously and convert these values to blood glucose levels. So these are the recommendations. Particularly the patients who are receiving multiple doses of insulin, the type 1 diabetes or very longer duration of type 2 diabetes when the patients are insulinopenic. So we used to give the basal bolus treatment or multiple dose insulin regimens, particularly the patients who are on insulin pump. When there's a concern of hypoglycemia, so where the patient have either the frequent hypoglycemia, severe hypoglycemia, nocturnal hypoglycemia, and particularly the hypoglycemic unawareness. This is a very grave complication of diabetes, particularly the type 1 diabetes, when a longer duration of uncontrolled hypoglycemia makes the patient, the autonomic dysfunction, and that gives the this hypoglycemic unawareness, so the patient do not feel even if the blood glucose level are very low, critically low. Again, the type 2 diabetic patients, this is recommended even who are treated with less intensive insulin therapy. Maybe in certain patients, in my practice do, when we actually initiate the insulin, we can't understand by the patients, the diet, that when the patient is actually taking a heavy meal. So I sometimes do this continuous glucose monitoring to check what is the meal pattern of the patient, and according to, I give the first, the bolus insulin of the patient according to this CGM data. So apart from this, definite indications like the patient who have, the pregnancy in certain patients we can do in infants and children receiving the insulin therapy. Whatever be the insulin regimen, we can go forward with this continuous glucose monitoring, like who are receiving the basal insulin, who are receiving the basal bolus regimen, or maybe some weighty patients like, sulfonylureas, glenides, particularly when there is unexplained hypoglycemia. The patients who have irregular schedules, skip meals or small meals, vigorous exercise, and the disturbed sleep schedule, shift work. So these may be the indications of this continuous glucose monitoring requiring increased accuracy. Coming to the different other methods that we have to monitor this kind of glucose, like we have the SMBG, that is a self-monitoring of blood glucose, but what is the disadvantage of this SMBG? It gives only the number of the fasting PP and don't give the full day glucose profile. So actually we ask the patient to either measure the fasting glucose and the post-breakfast, 2 hours after breakfast, pre-meal, pre-lunch, 2 hours after lunch, pre-dinner, 2 hours after dinner. But in between, if there is a glycemic excursion, definitely we will miss by this SMBG data. But this continuous glucose monitoring will give you the, the whole day profile, so there is no chance of missing any glycemic excursion or the hypoglycemia. Again, the HbA1c, very crude method nowadays because it gives the 3 months average blood glucose. So, and I already said there's a very poor correlation of the HbA1c with the hypoglycemia, whereas the hyperglycemia correlates well. So definitely HbA1c that will give the 3 months blood glucose, but do not offer the details about the impact of meal, the medication, or the exercise on the blood glucose level. Coming to the 2 very common names, the ambulatory glucose profile and the continuous glucose monitoring. So ambulatory glucose profile is nothing but a summary of 14 days of the continuous glucose profile in a day. So, but the problem is that ambulatory glucose profile is at less accuracy. It's only the 60% accuracy, whereas the continuous glucose monitoring gives around 98.4% of accuracy, because this ambulatory glucose profile, they do not, they require the calibration. So this is a busy sheet, slide that gives what is the advantage from the patient's perspective, from the doctor's perspective, at the same time the caregiver's perspective. And as Madam already said, that if we can allow this device to get connected with the mobile device, then definitely the alarm with a hypoglycemic or hyperglycemic alarm that can be given to the patient. So definitely patient will understand, okay, this time my blood glucose levels are going down or going high, so that will make the patient more alert and make the insulin dose changes. So this is the glycemic variability. It can be of 2 types, either the interday or the intraday variability. That means within a day, that is the intraday, and day to day, that is the interday variability. Because of the high glycemic variability, that gives to the high oxidative stress, and that means the more of the microvascular complications, at the same time chance of the severe hypoglycemia. So these are the different metrics that we actually calculate while we do this glycemic variability. The first is the most important is the amplitude that we done by the MAGE, that is the mean amplitude of the glucose excursion. Whereas the others like the high blood glucose index or the low blood glucose index that we can take care. Otherwise, the timing of the glycemic variability, that's also very important, and that we do by measuring the time in range, time above range, and time below range. So, American Diabetic Association and other guidelines are also there that actually dictate what is the what should be the time in range, time above range, time below range for a particular category of patients. Like the young patients, they have instructed to make the time in range of almost more than 70%, whereas the percent of time below range, that is the hypoglycemia, should be less than 4% of less than 70 milligram per dl, and less than 1% of less than 54 milligram per dl, that is the level 2 hypoglycemia. Whereas the time above range, that is hyperglycemia, is less than 25% of more than 180 milligram per dl and less than 5% of more than 250 milligram per dl. But this is not a hard and fixed. It should be individualized, so it's different from an elderly patient, it's different from a pregnant category of patients or the patients with a lot of comorbidities or the complications. Coming to the similar kind of slide I have already presented. So a patient with a HbA1c of 6.3, you can see the patient of 6.2, 6.1. So it's almost a similar category of patients with a good glycemic control. What we are thinking from the HbA1c, but what we can see here, in the first patient, we can see only the time in range is 56%, but time below range is almost 13%. Whereas in the second patient, it's a bit good, 61%, but it's still low with the criteria. Whereas the third patient, 6.2% with 82% of age of this time in range and less than 1% of time below range. At the last patient, the 6.1% A1C, what we can see is a 92% in the time in range and 8% time above range and 0% in time below range. So this is actually, that should be the patient's, the glycemic control with a less glycemic variability with a good, the HbA1c report. So this is a correlation of the HbA1c with the time in range. We all know that there is a good correlation between the A1C and percent of the TIR across a broad range of the subjects, says technologies above this across 18 subjects, and here for every absolute 10% change in the time in range, that there was approximate 0.8% reduction in the A1C. So what if the HP patient's A1C is 6.7%, we can assume that time in range is close to 70%, whereas more than 7.5%, the time in range goes below to 60%. So there is a relationship between this time in range and the mean glucose. So when the patient's blood glucose level is less than 120, this relationship between the time in range and the mean glucose is actually, the reversely fall, whereas when the blood glucose level is more than 120, there's an inverse linear relationship between this time in range and the mean glucose. So if we can correlate this time in range with the coefficient of variation, that we can see that as the coefficient of variation goes high, the time in range, it actually increases. So low glycemic variability, that means low the coefficient of variation, that gives low mean blood glucose and better time in range, whereas the high glycemic variability, that means the low time in range. So time in range is lower in those with high glycemic coefficient of variation and high glycemic variability, even in those patients with the same A1C. So the implications of this glycemic variability, this is a study that we all know, that DEVOTE trial with a insulin, where the deglutec insulin has been compared with that glargine insulin, and we can see the cardiovascular outcome compared as per the MACE and the all-cause mortality. And this is a patients with low variability, with medium variability, and high variability. When we see the patients with a high variability definitely have a high rate of, the MACE and all-cause mortality compared to that of the low variability. So definitely the fasting glucose variation, glycemic variability significantly increase the risk of the this MACE and all-cause mortality according to this DEVOTE trial. Again, this is a 10-year experience of developing diabetes-related complications after improving the time in range in type 1, type 2 diabetes, and we can see all the parameters like myocardial infarction, the end-stage renal disease, the vision loss or amputation, all there is high high of this time in range when it's more than 80%, whether it's a type 1 diabetes or it's a type 2 diabetes. So definitely the three pillars to manage this glycemia and the chronic hyperglycemia by this DCCT, that's a type 1, and UKPDS for type 2 diabetes, has demonstrated clearly the link between A1C and development of diabetes-related complications, that every 1% increase in HbA1c, which leads to the high range of complications, particularly the macro and microvascular complications. Again, the hypoglycemia, there's another pillar of diabetes management that limits the factors in treating patients with diabetes, and glycemic variability is the third factor that is definitely it's an emerging glycemic target, and this TIR and the glycemic variability are mathematically and conceptually linked, and they're not interchangeable. So this is a patient who have, the before treatment of this concept of this glycemic variability, and after changing the treatment, we can see in the second graph how this glycemic variability has been decreased, and that leads to definitely makes the patient more in the time in range with less hypoglycemia and less time hyperglycemia. So this is the AGP report that gives you, the different parameters that from which date to which date this AGP being applied, and at least the 14 days of AGP, the installation is required, and adherence should be at least more than 70 to 80%, which is 99% here. It will give the different glucose range, that is time in range here, 70 to 180, but that is definitely individual. It should be individualized according to patient's category. Where we can see it's greater than 70% in this patient. Hypoglycemia below 70 is around 4%. Below 54, that is level 2 hypoglycemia is less than 1%. Hyperglycemia more than 180 is 25%, and more than 250, that is very high hyperglycemia is less than 5% of the patients. So they also give the average glucose here, and the glucose variability is 49.5%. So target of this glucose variability is less than the 36%. So how to interpret this ambulatory glucose profile? There's a model gauge graph. There is a median line, and some other terms are there that this may be new to you. There's an interquartile range, interdecile range, and the target blood glucose. I will give you in picture. So this is a model day graph where the blood glucose data is collected for 14 days and is represented into a single day graph, that is the ambulatory glucose profile. So here AGP is a summary of the blood glucose from the report with median of 50% and other percentile shown as if occurring in a single day. So this is the, you can see the median line. So this is the median line that gives the average glucose at each point of time in a day, and it provides a visual trace of whether average glucose is within the target range and how much it swings up and down throughout the day. Coming to the second the term, that is the interquartile range, that is the inner blue part that gives the 25 to 75th percentile around the median line. And the third is the outer gray shaded band, that is the interdecile range, and that gives the 10 to 90th percentile around the median of the blood glucose. And this is the target glucose range where most of the glucose readings should be in a particular patient. So this interquartile range, that's actually half of the time, and that indicates how the medication and the meal times are influencing the blood glucose control, whereas the second, that is the interdecile range, that gives the glucose variation that is happening on some days and indicates how the behavior, that is the lifestyle of the patient, impacting on the blood glucose level. So there's a step-to-step approach. First is we have to search for the hypoglycemia, then the hyperglycemia, and third is the glucose variability. So here we can see that the patient have a 24% below the target, and the low glucose events were almost 27, that is almost 131 minutes in a day. Again, there's a second part, that is a hyperglycemia. So look for the trends towards the high blood glucose above the upper limit of the target glucose. And third is the glycemic variability. So in the first, the first profile, we can see this is the narrow blue IQR band, narrow gray IQR band. So that means the patient have a low day-to-day glucose variability, at the same time low occasional glucose variability. So there is no treatment adjustment that is required. Whereas in the patient 2, we can see there is high IQR. That means the patient's, actually the day-to-day variability of glucose is very high, but this DR is actually low. That means low occasional glucose variability. So that means these patients actually require treatment modification by the time, like the mealtime insulin dose and the timing, the suboptimal, the correction of the dose calculation, suboptimal insulin carbohydrate ratio. So these are the important issues that we have to take care while this kind of patients we handle. The third patient, where we can see that this IQR is narrow, but IDR is very high. That means the patient have a high occasional glucose variability, where the day-to-day variability is not so much. So definitely here the behavioral and social aspects we have to take care, the lifestyle modification. We have to search for whether the patients are actually missing the injection, irregular meal time, unplanned snacking, alcohol consumption, and definitely the unplanned exercise. And the fourth patient is the poorest patient who have a white blue IQR at the same time white gray idea. That means both the day-to-day variability and the occasional glucose variability both are high, so that needs all the correction lifestyle modification at the same time, the medication or the insulin dosage. So how this AGP can guide the therapy? Definitely we have to all find out the different, where is the change is required and whether the insulin dosage or lifestyle modification, we have to do it at properly. Coming to the, this kind of daily glucose log, they also help to identify the which part of the week that is actually, makes the patient more vulnerable to hypoglycemia. Like in this patient, we can see the weekends, the patient, the Friday, Saturday, the patient have a high blood glucose, particularly the post-meal kind of blood glucose, and also have a frequent hypoglycemia that is detected by this red part of this glucose monitoring. So definitely the CGM is guidance for the insulin users. It will help to identify the glycemic the pattern after the initiation of insulin. It's the best possible dose adjustment can be met by this continuous glucose monitoring. Treatment goals can be defined. It will ensure the increased treatment satisfaction and adherence, and therapy intensification is possible, keeping strict eye on hypoglycemia and to avoiding hypoglycemia, and definitely helps to overcome the clinical inertia. So with this, thank you for your kind listening, and may I request the chairpersons to proceed.
Thank you, Arindam, for your wonderful presentation. You come here. We can have questions from the audience related to the device, related to the application, related to the practical aspects, because whatever you have heard now, the terminologies, you may not be very familiar. I don't expect you all to be familiar unless and until you use it. So for practical things, I would like to ask Arindam, where are you actually recommending CGM for your patients? Which category? Because it's a costly affair, it's a costly device. So specifically, apart from the indications given by the ATDD as well as ADA, August bodies, practically ground level where you are using.
Madam, here some of the patients who have actually very poor glycemic control, like the patient's HbA1c is not achieving properly, but we can see the patient's fasting and PP is well controlled. So which part of the day that is contributing to the high HbA1c, that is not identifiable, and patient is refusing to do every time this SMBGs. So this is one of the very important indication in my practice to do this continuous glucose monitoring. The second thing is the patients who have the hypoglycemic unawareness. The patient have a very blood glucose low, and the patient, I'm feeling that the patient may have a impending hypoglycemia, severe hypoglycemia, and the patient have a very good glycemic control. So whether I have to reduce, but patient have a very long duration of diabetes, so strict glycemic control is also necessary from other aspect. So in this category of patients, definitely again this this continuous glucose monitoring will definitely help. The third category, I have already mentioned, the before initiation of insulin, some of the patients I do this continuous glucose monitoring to check what is the lifestyle of the patient and what is the meal pattern of the patient, which gives my, force me to give the insulin particularly before a meal, that is gives the high glycemic excursion or postprandial excursion. Apart from type 1 diabetes, as Madam already said and all the August bodies said, so these are the special indications that I feel we can actually use this CGM.
Dr. Bhattacharya, what are your experiences? Apart from what Arindam told, could you specify other categories, which I feel I may summarize, but your practical experience, where do you use it, apart from what Arindam has highlighted? I think you will agree with what Arindam has said, but apart from that, where you feel its use can be utilized, I mean the CGM can be utilized.
It is unnecessary to talk anything more because everything is covered by Arindam already, but in my clinical experience, I will tell that where the HbA1c is 8.5%, but fasting sugar 106, PP sugar 142. There is a discrepancy in between the fasting PP and HbA1c value. CGM is having the greatest value in these type of patients. Actually, the fluctuations of blood sugar is related to the glycemic damage by oxidative damage, advanced glycation end products, and inflammatory markers increase, etc., etc. So we have to minimize the fluctuations, glycemic excursions, and the persons particularly who are having multiple daily injections, like 3 injections or even 2 injections, we are very reluctant to increase the dose, but the patient is having on insulin. In this group of patients, CGM is very useful, whether it is causing hypoglycemia, whether it is causing undetected hyperglycemia, despite the more or less acceptable HbA1c level. And third point I will tell, in the persons who are most likely to go into hypoglycemia, those type of frail patients, 70 years age, very low body weight, having kidney disease, CKD, maybe going to hypoglycemia and maybe having hypoglycemia unawareness as well. I will recommend in my patient population in CGM in these patients.
Absolutely right, yeah. Can you take the microphone?
I'm using this Freestyle LibrePro for last 6-7 years. I have got a huge data of my own patients, and I have presented in various CMEs of my patients' data. One particular class of patient I want to mention, apart from these indications, when patients come to me with a very high blood sugar level, around 300, 400, HbA1c 12, 11, upon initiation of insulin, when blood sugar comes down, some of my patients complain of hypoglycemic symptoms, though by definition they are not having hypoglycemia. Say blood sugar is, he is used to with 300, 350, when blood sugar comes down to 160 or 180, they feel hypoglycemic symptoms. This class of patients, I used AGP, this Freestyle LibrePro, to ascertain whether it is real hypoglycemia or the sudden fall in blood sugar causing this hypoglycemia. Apart from this, hypoglycemic symptoms. Apart from this, one thing is very important with this Freestyle LibrePro, that nighttime hypoglycemia, we can never diagnose nighttime at 1 a.m., 2 a.m. with run-of-the-mill CGM, that glucometer. So in that patients, in these 2 particular patients, apart from you said, this device is very, very useful.
Actually, if you put your patient on CGM, you will be wondering that how the glucose varies from day to day. You are taking lunch at 1:30 p.m., you are expecting that the peak will be at 3:30 p.m., but you are seeing that the peak is at 6 p.m. or at 7 p.m. Not
Hello.
after 2 hours, but after 4 hours. This will be very much visible in the CGM graph. So it is very useful tool, particularly if you want to ensure our patients a good control and good quality of life. Supriya Datta.
Just
Yeah,
one thing I
just-
want, hello, excuse
Okay,
me.
yeah.
I have seen some patients who are complaining of that hypoglycemia, palpitation, all sort of things, and used to take or used to fed by the relatives sweetening agents, the sweets and all these. And the patient come with a very high level of sugar after having this sort of meal and on these sort of foods. But it occurs very often. Patient seems that patient has been having hypoglycemia and used to take a lot of sweets after that. These patients, irrespective of good medication, is very difficult to determine whether actually he is hypoglycemia or is something other. And after that, having some sweets and all this, he is getting a hyperglycemic episode. So in these sort of patients, in aged patients who are very often going in hypoglycemia, is that I think these patients should have a CGM to actually sort it out that whether it is hypoglycemia or something other than that. And patient when reports to the clinic, he often comes with a very high blood glucose level, though he is having the experiences of vertigo, this palpitation, sweating, everything. But actually whether this is hyperglycemia or something is other than that, for that reason, I think it should have a positive role, that if you do a CGM or a GP, it will give you the guidance that
Okay,
actually
sir.
it is hypoglycemia.
Right, understood. Your point of view, actually, in practical life, these patients never monitor their blood glucose.
Right.
Without monitoring even a prick, I mean, self-monitoring of blood glucose with a glucometer. So you do not use a costly device for that. Patient will never afford it, never go for it. For them, if it is happening recurrently, like Arindam pointed out, a patient who has a brittle diabetes, having offs and ons, I mean hypo and hyper, as well as autonomic failure, hypoglycemia unawareness, there you can always use this, convince the patient, because it is distressing to the patient and also goes cardiovascular complications, arrhythmia and all those. For that, it is okay. So to summarize all what has been discussed, and we actually, for type 1, it is definitely recommended. For pregnant women with very high sugar, pre-gestational diabetes, it is recommended. And in type 2 diabetes, where these situations, this HbA1c not correlating with the blood glucose levels, fluctuation of blood glucose, apart from that CKD and patient on alcohol, hepatic disorder, where hypoglycemia chances are there, those patients, and also in-house, one point has been missed, during the acute infection, COVID and all those, any acute infection in the hospital, instead of pricking every time, it's better to put the patient on a CGM, and it would be better to adjust the dose of insulin. So absolutely, this is a very good innovation. Only the cost is the barrier. This application, as you saw, it's very simple, and patients initially, they may be scared, but once you apply, they are very easy with it. And those who have these fluctuations of blood glucose, they come to know when to eat, what to eat, when will be the exercise timings. Because of the medications, if the patient exercises, there'll be hypoglycemia. So how to take the pre-meal, I mean pre-exercise snacking and post-exercise snacking, all these will come into the picture with a CGM. So we actually expect a lower price device to come for the benefit of our patients. Definitely there will be more innovations. Latest is the contactless, the latest glucose measuring device which is coming. This is continuous, but the latest with a smartphone, without a contact also, you can monitor blood glucose. That's there in the Western countries. So for the benefit of our patients, we will require that. So, so this will be the last question, because our next speaker has come and we are already late. Sir, be brief so that we can wind up the session.
This is not a question. I think it has a very good opportunity, or a good exposure can be in the normal healthy people who are on endurance sports.
Yeah.
So the dietitian, especially the sports dietitian, can plan the drinks, intervals,
Yes.
and the type of diet they are taking, so that they can increase their efficiency and the performance.
This is being used. I was going to go into it,
It is
because of
being
the lack of time, I am not going into it. And we have
Actually,
had a very good discussion, sir.
What I heard, that it is only due to friction, it can be dislodged from its site. But in the body contact game like football, and especially in the underwater games, whether it is efficient or not.
Even in the underwater games, it is being used because the device works absolutely fine. And for football players and cricket players, everywhere in the world, the dancers, acrobatics, they are using it. Type 1 diabetes, we can name a few. Wasim Akram is a common example. Apart from that, Miss Shethi, Shonakshi, right, they are using it. So it's a very good device. So we wind up this session. It was a lively discussion. Thank you all for the patient hearing.
Thank you so much, sir. Thank you, ma'am. It's time to felicitate our speaker. I would like to request our chairperson to please felicitate our speaker. Thank you so much. And I would like to request Dr. G.P. Bhattacharya to please felicitate Supriya ma'am.